Okay, it is my pleasure to introduce our speaker, Professor Martin Stoddard. Professor Stoddard leads the Regenerative Orthopedic Program at the FIOR Research Institute in Davos, in Switzerland, where he focuses on advancing bone and cartilage repair using patient-derived mesenchymal stem cells, particularly exploring mechanoregulation's role in mesenchymal stem cell chondrogenesis. Professor Stoddard's academic journey began with a bachelor's in biology and an MPhil from the University of Aberystwyth in the UK, followed by a PhD in oncology from the University of Nottingham in 1999. His research career led him to the Lab for Experimental Cartilage Research in Zurich, Switzerland, and then to FIOR in 2005. He holds professorial roles at Albert Ludwigs University in Freiburg, Germany, and Kiel University in the UK. Recognized for his significant contributions, Professor Stoddard was elected Fellow of the Royal Society of Biology, FRSB. In 2016, he received the Themis EU Mid-Career Award in 2020 and was inducted as a Fellow of the International Combined Orthopaedic Research Societies, FIOR, in 2022. With over 180 publications and an H-index of 47, he's a prolific contributor to the scientific community. He has mentored more than 90 trainees, including 13 PhD students, and is highly sought after as a speaker at international conferences. Professor Stoddard is also a leader in regenerative rehabilitation, serving on the International Consortium for Regenerative Rehabilitation Leadership Council and as a member at large for Themis EU and Global. He serves as editor-in-chief of European Cells and Materials Journal, associate editor for Frontiers in Biotechnology and Bioengineering, and as a member of the editorial board for the Journal of Functional Morphology and Kinesiology. Please join me in welcoming Professor Martin Stoddard. It's all yours.
Yep, thank you very much, Jackson. And it's a great opportunity for me, and I'm quite excited to be able to give these kind of international lectures. As you probably realize from my accent, I'm not actually from Switzerland originally. I'm from the UK, Northern England, to be a bit more specific. And the building you can see on the screen at the moment, this actually is my research institute, so I'm quite fortunate to be in a place where we work and live in the mountains areas, and we have a lot of sporty activities. And so before I get into the topic of the conversation, which is going to be this activation of TGF, most people have never actually heard of the AO Foundation. I work at the AO Research Institute, which is the AO Foundation's research arm. So just a brief introduction to the foundation itself is because most people know what the AO Foundation does, they just never heard of us. And so essentially this is the group of surgeons in the 50s which developed these metal implants. So if you break a bone, if you break a bone, quite often you'll see people have a plate put in, a screw, a nail. This idea to use metal against bone to fix bone fractures is what started this whole concept of the AO Foundation. So why this is really quite important, again, for today's talk as well, it's because the AO is surgeon-driven. I spend a lot of my time talking to surgeons. And that means we're always looking for how can we improve clinical treatments and how can we take our lab-based research and make it more relevant for patient care. And so this is just to give you an overview roughly of how my research group views the world. We work around this idea of bone marrow-derived stem cells, or MSCs. We also work with other sources, fat, muscle, synovium. We've worked with various different cells over the years. We work mainly with bone marrow because That's the cells which our surgeons are familiar with. And what we're very, very interested to know is how can we predict what bone marrow cells will do? So we know that some donors work, some donors don't work. I'll come back to this idea of how in vitro and in vivo complexity. What this means is quite often what we do in the lab will give very reproducible data, which when you then go back and say, okay, what actually happens in a patient, we don't see the same things. And so what we're trying to do is we're trying to make our in vitro models match much, much better what actually happens in a patient so that the experiments we do are more predictive. And then the main topic of today's presentation is how does mechanics regulate stem cell fate? And so I'll give you some examples of how we know in patients the mechanics does regulate quite strongly stem cell fate in orthopedics. And then I'll transition that into how we've been modeling this within the lab. So the main thing I'm going to talk about today within the work we do, because we work on bone and we work on cartilage, but for today's talk, I'm going to be presenting predominantly the cartilage work. And if you look at articular cartilage, it's the soft tissue which coats bony ends. It allows for pain-free motion. If you get osteoarthritis and the cartilage is removed, then quite often you'll feel the pain and you'll realize exactly what your cartilage is for. When you look at the structure itself, it's actually quite simple. It's got a superficial zone, it's got a middle zone and a deep. It does not have blood vessels. It does not have nerves. So when you look at it, it's a very simple tissue. You have a few cells embedded in a matrix. And so when you think about tissue engineering or tissue regeneration, this was one of the early tissues where people who wanted to do this cartilage repair, we thought, well, this must be quite easy. It's just a few cells and a bit of matrix. How difficult can this be? Well, the reality is it's been extremely difficult. And this tissue heavily relies on mechanics. And a lot of the things we do does not rely on mechanics. And so there's been a big disconnect from promising therapies in the lab, which then when they're tested in animals or they're tested in patients, they just don't align. So when you look at what our current options are, if you were to have a cartilage injury today, what would your treatment options be? And so essentially one of the more modern ones is this autologous chondrocyte implantation. So chondrocytes are the cells from cartilage. Autologous means we take the cells from the patient. So what you would do is you'd have a damaged area of cartilage. You would then take a biopsy of tissue, cartilage. You'd isolate the cells, the chondrocytes. You'd grow them in culture in the lab to make many more cells. And then you'd re-inject it into the defect under some kind of a patch or some kind of a matrix carrier. An alternative method, which is by far the most common one for smaller defects, is if you have a cartilage defect, the surgeon will scrape to the bone, scrape away the calcified zone, puncture holes in the bone, and then this gap will fill with a marrow clot, which has bone marrow-derived MSCs in a fibrin gel. And so the problem with both of these methods is the tissue produced, it doesn't really last very long. Patients will be very, very happy for a few years, but normally what will happen is they will come back and then these things will fail. The other thing when we consider from a surgical and a clinical point of view is if we accept the fact that mechanics can change how these cells behave, it's quite surprising to me that there's no widely accepted or proven rehabilitation protocol. So if you have surgery, you can have various different options, and what the clinician will recommend will vary depending on the clinician's preference. And so when you think about this microfracture, we have MSCs in a fibrin clot. And in the lab, what we know is the MSCs are this mixed population of cells, mesenchymal stromal cells or stem cells. If you look at the literature, my personal preference is mesenchymal stromal cells. They can differentiate into cartilage, bone, and fats. They can also produce soluble modulators, so people are talking more and more about their secretome. When we isolate them in the lab, it's fairly rudimentary. We just put the cells from bone marrow on plastic. If they stick and grow, therefore they're stem cells, which is personally, I don't believe that's to be true. But one reason why this is really important to us in the orthopedic world is we know that the decision these cells take, whether it be cartilage, bone, fat, or fibroblast or other cell type, is heavily affected by mechanics. And when we've been trying to take these cells into the clinics, if you were thinking about an autologous therapy where you actually take bone marrow, grow the cells and reimplant them, this road to translation was supposed to be straightforward. It was supposed to be, we'll take the cells from the patient, we will grow, stimulate the cells in the lab, maybe make monolayer or make 3D tissues in some kind of tissue engineering approach, and then we're just going to reimplant the cells. It's very, very simple. But we've been talking about this now for over 30 years, and we're still not there because the road to translation has actually been a lot more complicated and a lot more windy than we first thought. So within our group, we started to think about this starting from the patient perspective first. And so what are we actually trying to study? If you think about it, we'd have a patient with a knee joint. You can see this schematic of the knee joint. You'd have an injury for somewhere, a traumatic injury. And that injury then has multiple loads which exposes when you're walking, when you're just moving in daily life, and people want to remain sporty into quite elderly patients now. There's the immune system response, there's blood, there's damage, there's a lot more complicated cell-to-cell interactions going on. And how we tend to study this is we will put MSCs in a gel, and then we'll put this gel in a static dish, and we'll put that under static conditions. So this does not mimic at all what is going on in a patient. And I'm going to keep repeating myself throughout the whole presentation. The mechanics the cells experience and the tissue experiences is dramatic in deciding its outcome. And so here, when you have no mechanics, that could be a challenging problem. So when you look at MSC chondrogenesis, and this is the process where you take these progenitor cells and they differentiate down pathways, the one we want is this to an early chondroblast progenitor, which then goes towards stable cartilage and becomes a stable chondrocyte, leading to permanent cartilage and a repair of the cartilage tissue. But when bones heal, bones actually heal through a similar process. The cells themselves differentiate to an early chondroblast, which then becomes towards this hypertrophic chondrocyte and then remodels with bone. So in normal bone healing, we have cartilage formation first, then bone follows. So when you look at mechanical regulation studies on this kind of differentiation protocols, there are lots and lots of studies out there where they take a stable chondrocyte, they'll have cartilage tissue, they'll isolate the chondrocytes from the tissue and put them in a 3D matrix and load them. There are lots of studies out there where they have a chondroblast, and the way they do this is they will take this progenitor cell, they will give it a signal to tell the cell to become chondrocyte-like, and in the labs, this is a protein called TGF, it's the title protein in this particular presentation, transforming growth factor beta, and as people will give the cells transforming growth factor beta, induce this early stage, and then see how the mechanics regulates the later transition towards stable or proliferative chondrocytes. We've been focused on this step. What happens if you mechanically stimulate the early progenitor with no TGF in the medium? We give no soluble factors. And the reason why we do this is because we want to mimic this kind of environment where you have a progenitor cell, an MSC, in a fibrin clot, this mesenchymal clot, after microfracture. And then when you're looking at the clinical translation, the idea would be is the patient would get the same therapy they get now, but we would try to improve the outcomes by changing the mechanical forces applied to the tissue when we then load. And just to give you an idea, I've mentioned this concept already about bone healing, which I'm just going to touch upon because it's such a dramatic, easy to see change in the tissue formation with mechanics. So if you have a bone fracture, you have a hematoma between the bony ends. So this is one bony end, this is the second bony end. Though that hematoma between the fracture will have mesenchymal stem cells. And what we know from many years' work is If the fracture ends are completely rigid, this type of metal plating system would mean there'd be absolutely no micromotion between the fracture gap. Those cells will go straight towards an osteoblast. However, if you take exactly the same cells with the same kind of fracture gap and you have motion, in this particular case, the classic example is you break your arm, you have a plaster cast, you can still move, you have some micromotion. So the cells experience mechanics, you get a cartilaginous template first. And this has been shown in studies, multiple studies. This is where we have a wedge of bone. And on the right-hand side, that wedge of bone is held completely rigid. On the left-hand side, that wedge of bone was tilted 10 times a day for 5 weeks, so a little bit of movement. And what you can clearly see here is there's no real bone formation in this gap when you don't have any motion. Here you can see the gap filling with tissue which is calcifying. What you can't see is the cartilage here. And this cartilage is calcifying and remodeling into bone. So this is a very dramatic example of how a little bit of motion can dramatically change the outcome of the cells within these gaps. So now we know this happens in a patient. We then come back to the lab situation. And in the lab, when we're doing this in vitro chondrogenesis, we make some assumptions. And one of these is if we take static culture and we take our MSCs and we embed them in a gel, because chondrogenesis likes three-dimensionality, we add the transforming growth factor beta, which is exogenous, we just put it in the medium. If you put all of these combinations together, you do get chondrogenesis. But the assumption has always been that chondrogenesis is the same as what's going on in the patient. The other assumption, which we've been using a lot, is when I first started these studies more than 20 years ago, a lot of us had bioreactors where we could apply uniaxial load. We could compress samples. And if you do that with chondrocytes or cartilage, you get a positive response, you get more matrix being produced. But that assumes, though, that the signal which maintains chondrocytes and makes them build more matrix is the same signal which tells an MSC to become a chondrocyte. And it also assumes that this complex load you can see in these GIFs is not important. The uniaxial compression is everything. And over the next 20 minutes or so, I'm just going to hopefully convince you neither of these assumptions are true. So in our lab, we've been working with a very complicated bioreactor system. It's essentially a ceramic hip ball, which you can rotate the hip ball to apply shear. You can move it up and down to apply compression. You can move the holder with an offset or not. You can see one of our finite element models showing you how this ball would rotate over the scaffold, which is this cylinder at the bottom. This is the tissue of interest we want to load. This is our bioreactor. And with this, we can mimic the knee joint, the hip joint. We can mimic very complicated load, which an articulating joint would experience. Most of the work I'll discuss today is this plus minus 25 degrees oscillation of the ball at 1 hertz. And we also have 1 hertz of compression and shear. The reason why we choose this frequency, we can actually improve the outcomes with a higher frequency. This frequency is kind of a slow walking pace because we keep trying to relate this back to a patient. If the patient's just had surgery, they're not going to be able to run around or be a high frequency load. And to give you an idea of how this changes the outcome parameters when you start to grow cartilage, is if you look on the right-hand side, this is histological sections from natural cartilage from bovine or cows. The matrix products we really want is this collagen 2. So you can see there's lots in bovine cartilage. There's a little bit of collagen 1 on the top. In cartilage, collagen 1, generally speaking, is really bad. You do not want this. Agrican is a matrix molecule, which is very important in cartilage. So again, in the natural tissue, you see it very evenly distributed. And as the two surfaces rub together, you need a lubrication system. And in part, this is this protein called lubricin, which you can see a thin film of on the top of the cartilage, which helps it rub against the counterface on the other side. So if you take a non-loaded scaffold, and this is classical tissue engineering, you take a scaffold material, you embed, in this particular case, bovine chondrocytes, and you grow it static conditions like I demonstrated earlier, you can see the cells will make some collagen 2, which is good. They make a lot of collagen 1, which is not good. That's very bad for what we want to do. Aggrecan's fairly evenly distributed, and there's no sign of any of this lubricin protein on the surface. If you load this sample just by uniaxial compression, so just the up and down motion, you see a bit more of an even distribution of collagen 2. You can see the collagen 1 does start to redistribute itself nearer the surface of the cartilage. The aggrecan is evenly distributed as before, but there's still no sign of this lubricin. When you superimpose shear and add shear over the load, now you really start to see differences. There's much more collagen 2, much more evenly distributed. The collagen 1 forms a thin film on the surface where it should be. Aggrecan again starts to more evenly distribute as it normally does, but you now get this thin layer of lubricin and this lubricating protein on the surface. So with this series of pictures, you can really appreciate how the load can help tissue mature. And this is what would happen in a patient. But this is with bovine and it's with articular chondrocytes. So the work in my team, we've been focusing on this method, one we've already mentioned. We know these cells can undergo chondrogenesis, and my research question has been, can we use the patient as a mechanical bioreactor? And if so, what kind of load should we be applying to that patient to get during a rehabilitation protocol to improve this human mesenchymal stem cell or stromal cell differentiation? So some of the early work done by Chen Li, we would take adult human bone marrow MSCs. These could be ranging from patients up to 80 years old, because elderly patients have injuries too. We embed them in fibrin because that mimics the clot. And then we held them together in a polyurethane scaffold. So you can see the histology here, the upper surface, these black dots embedded in the gel, which are the cells within the fibrin. So this loosely mimics the mesenchymal clot after microfracture. And what you see when you add this 10 nanogram TGF-beta protein, and we saw this very reproducibly, is the cells do not respond to load. When you're looking at gene expression of the aggrecan matrix molecule or the collagen 2 matrix molecule, 10 nanogram TGF-beta in the medium plus load was reliably telling us that load has no effect on MSC cell fate. Whereas you've seen yourself from the fracture, the bone model I showed you earlier, we know in a patient it does affect. So then we started to ask a simple question, where does the TGF-beta come from in a patient? Because we don't have PhD students giving 10 nanogram TGF-beta every 2 days in a patient. When you take away the TGF and just apply the load, now you see a big response. You see a big increase in aggrecan expression, a big increase in collagen 2 expression, and this is purely driven by mechanics. There is no serum in the medium, there's no growth factor in the medium, this is just a pure mechanical response. It's dose related. If you add 1 nanogram TGF, you start to get some matrix expression, and you do still have an effect to load, and then as you add 10, that response to load is gone. And so now all the studies I'll show you from now on, we don't add exogenous TGF, we do this no TGF control, and then we apply in the mechanics and see, can we improve the chondrogenic differentiation? So again, we're trying to bring this chondrogenic differentiation back to what we see in patients, and there's lots of fracture models out there. There's a lot of in silico models, and for example, this one from Prendergast, which has been improved over the years, proposes that if you increase tissue shear strain and fluid flow, the cells in that fracture callus will move. As you increase the fluid flow and the shear strain, you'll get more cartilage. And if it becomes rigid, like in a plating system I showed you earlier, they go straight to bone. Well, if this model is true, and we know it is because of the way patient heals, what this tells us is in our bioreactor, if we increase the frequency and amplitude of the load, we should push ourselves more towards cartilage if we're validating what goes on in a patient. And this is exactly what we see. As you increase the frequency or the amplitude of load, you increase the expression of collagen 2 and aggrecan matrix, which is associated with cartilage. And this is a frequency and amplitude dependent manner. What we also see is some other genes are regulated, some of the ones we might not want to see, for example, those in bone. They also increase in a frequency and amplitude manner. So what we need to try to work out here is when we apply a uniaxial compression, we're increasing fluid flow. So could it just be that all the genes are going up because we're feeding the cells better so they make more of everything? So more and more we started to look at ratios of the genes we wanted versus the genes we didn't want. So if you look at the aggrecan versus collagen 10, the collagen 10 is on this hypertrophy pathway. This is the collagen associated with cartilage going more towards hypertrophy, going towards bone. As you increase the frequency and amplitude, the aggrecan goes up more than the collagen 10 does. Similarly, if you take the collagen 2, the cartilage collagen we really want, that also increases expression over the expression of collagen 10. So with the highest frequency and amplitude, you're getting a 3-fold increase of collagen 2 over collagen 10. So this is showing it does exactly what we expected it to do. We push the tissue more towards a resting cartilage and away from a hypertrophic cartilage. So when you start to think about patients again, which is, again, we keep coming back to this topic, does this fit what a patient does? We think it does. So now we need to think about, okay, so what kind of rehabilitation should we be thinking about with our patients? And because of the way the system works with the various different motors we can turn on and off, we can do different experimental groups. We can have free swelling, which is the classical static culture in an incubator, which would mimic a patient in bed rest. They have to wait in bed. Compression alone, which we do 10%, that would mimic a treatment where they put the patient's leg into a brace, they lock the brace so the patient can load, but they can't bend their knee. Shear, we can mimic, and that's also a treatment, which is a machine where the patient lies in bed, they put their leg in this machine, and the machine will bend their leg for the knee without applying load. And then compression and shear, which is basically weight bearing, if the patient's moving their knee and walking as normal. So by turning the various motors on, we can recreate all of those conditions. And what you can clearly see when you look at the genes you want, like collagen 2 over collagen 10, or collagen 2 over another bony-related protein called alkaline phosphatase, compression alone does nothing in changing the fate relative to free swelling. Shear has a minor change, but compression and shear changes this to really push a chondrogenic differentiation. This you can see in the histology. A classical static culture looks nothing like cartilage. Compression alone just compresses this fibrous capsule, shear polishes it, but compression and shear leads to this matrix being produced within the scaffold, leading to more cartilage-like tissue formation. So now we know the shear is important. Could we think about how this might influence our tissue constructs if we were ever to make these to implant them in a patient? So this is work we did with Oliver Gardner, and in group 1, we did the classical tissue engineering approach. You take 5 million cells, you evenly distribute them throughout the scaffold, and then we load. Group 2, we have exactly the same number, 5 million cells, but we put 90% into the scaffold and 10% on the top, like a surface layer. This means those cells get more exposure to the shear from our bioreactor. And as a control, we had just 10% of the cells on top. And then when you look at the histology of the tissue we were forming, safraኖ is glycosaminoglycan, a cartilage molecule. Collagen type 2 is the the cartilage collagen that we really want to see. And just keep in mind, group 1 and group 2 have exactly the same number of cells. And there is no growth factors here. This has all been induced purely by mechanics. And you can really see much, much more cartilage formation when you have this asymmetric seeding. And the cells on top by themselves didn't really do very much. So this shows that mechanics plays a role. It shows that cell location plays a role. And it shows that we can induce this cartilage formation without any growth factors. So why is this? How does it actually work? Well, we collaborated with a group in Leuven in Belgium. And what you can see from the collaborations with that group is this is our bioreactor being modeled in an FE model. You can really see from this heat map of different strains where the cells are in this sample will experience completely different mechanical loads. So a cell in this area at the top would expose to a completely different load than one down here in the corner. Now, one aspect, if people are familiar with these finite element models, you can get lots and lots of different models. You can look at things like fluid flow, shear stress, principal component, strain, all sorts of different things producing different heat maps. So we wanted to say, okay, which matches the real world? So we took these finite models, we looked at all of these various different parameters, we looked at the heat maps, and then we went back to real world experiments where we had actually applied these loads to constructs and had the histology. And we produced heat maps based on the histology of our samples and compared those to the heat maps from the finite element models. And what landed up quite nicely was this principal strain field. So when you apply compression, it never really increased. When you apply shear alone, you get these hot spots where there's some activity. And then when you apply compression and shear, you get a lot of activity going on with this particular field. And this matched our histology extremely well. And why it's very, very interesting is if you remember the data from a previous slide, where, for example, with collagen 2 mRNA, compression alone didn't change anything, which is what you see here. You don't see any change. Shear alone has a tendency to increase the expression. And this, we believe, is to do with an artifact of PCR, which in these samples, within this sample, there's 5 million cells. When we isolate the RNA, we take those 5 million data points and lyse the sample, which means we end up with an N equals 1. And then what we're seeing here with this tendency is these cells have a higher expression, but it's being averaged out by all the other cells which didn't really respond. And now we have enough cells reaching the threshold that we can see a statistically different response. So if you ever work with PCR in 3D constructs, always keep in mind that this uneven distribution of response could be affecting your PCR data. And so now we're looking at this for PCR and materials designed for cartilage repair. So I know from discussions earlier that not everybody in the audience works with cartilage, not everybody works with bone, but one aspect which might still be quite of interest to your own particular work is this topic of TGF-beta. If anybody works with this particular growth factor, it's always worth considering the bioavailability rather than the concentration. Why that's important is because TGF-beta is something quite unique as a growth factor. I'm not aware of another one which works in this kind of way. The cells, when they produce it in the body, make it as a latent TGF-beta. So it's inactive, it's not functional. So production is one end of the equation, but then how is the TGF-beta switched on? The activation also needs to be kept in mind. And so only when it's activated can it bind the receptor and do all the signaling we want. So the activation can be pH related, it can be enzyme related, and these are the classical ones everyone normally talks about, but it can actually be mechanical. You can mechanically turn this protein on and off, and this bioavailability is linked to its activation. So when we looked at the medium, which when we were culturing these cells, what we saw was as you loaded the tissues, when you don't add TGF, you could find TGF in the medium. And this was so it was increasing production. And the production was very similar to the 1 nanogram TGF, the exogenous in the medium. And that explains some of the PCR data. But then we asked, well, how is it being activated? So this endogenous latent TGF-beta, what you can see from these graphs is with the loading protocols we applied, you see the activation of TGF-beta protein by the loading protocol. So essentially what's happened is the cells produce the latent TGF, we apply the correct mechanics, and that mechanics then activates the TGF being produced by the cells. We managed to show this is purely a mechanical activation because we did an experiment where we took the scaffold with the fibrin and the polyurethane. We did not add cells. We added latent TGF-beta into the medium. We mechanically stimulated for 6 hours, and then we could find active TGF in the medium, even though there were no cells present. So this is purely mechanics. So when I've had people contact me from like heart groups because they're looking at TGF beta and the heart's beating, and this mechanical activation might play a role in things like heart regeneration and all other features and scar formation. And so we know this is stiffness related, and we know this is Young's modulus related to the stiffness of the tissue. We also know from work from another group, which is in the US, where they took synovial fluid, which is full of latent TGF beta. They passed it through a needle at various different fluid velocities, and they can mechanically activate the TGF by fluid velocity through a needle. So we know this mechanical activation is quite a key event in when there's mechanically response to the tissue and to the loading patterns. When we look at more detail how this actually works, we've done a series of experiments where we either applied compression alone or we applied shear alone. And what you see is when you apply compression alone, you do not get activation of TGF in the absence of cells. This is cell-free. When you add shear, as you increase the shear, you increase the mechanical activation of the protein. Then when you compress, you find more TGF beta inside the scaffold because of the fluid change based on the compression of the scaffold. So when we're looking at this activation, the different loads have different functions to get the biological response. The shear activates the TGF, and then the fluid flow by compression pushes the active TGF into the scaffold. And so this mechanism, we're dissecting out bit by bit how we can optimize this mechanical activation. One practical example of where this can be quite useful is normally what would happen if we get materials to test for cartilage regeneration, you would add human cells, you would grow it for 3 months, you would do multiple donors. So to work out if a material is useful or not could potentially take 6 to 12 months. Now what we do is we take the material of interest, we do not add cells, we add latent TGF beta, we load for 6 hours, and then we do an ELISA looking for active TGF. And if we can see active TGF, we know we can do the cell work. Or if we don't see active TGF, we know it's a waste of time and we just saved a year's worth of work. And quite often what you see here with the cell-free system with the latent TGF then translates into cell-containing. We do not add TGF, the cells make it, we mechanically stimulate them, and then they mechanically activate when you have load, which you do not see this mechanical activation when we do not have load. And so just to give you a bit more of a perspective of where we're going next, because we're trying to recreate the patient's joint in the lab, is one of the projects we have running. If you think about soluble signals, if you have cartilage zone and then a bone defect, so the cartilage in this schematic is gray, the bone part is blue, a cell by the surface, this cell A, will see completely different signals than the one B or the one C, which is very much deep into the bone. So cell A will see the mechanics and the soluble signals from cartilage. Cell B will see soluble signals from cartilage and bone and still sense the mechanics, whereas cell C will mostly get soluble signals from the bone and a bit from the cartilage and not much mechanics. So we're developing this osteochondral explant model where we take a cartilage and bone plug, we drill a hole, we make a defect, we can then load this osteochondral plug within our bioreactor system, and so we can start to test therapies in their natural environment of bone and cartilage. We're also engineering the culture medium. The culture medium we use classically was designed to induce chondrogenesis. What we're asking is, what happens if we use culture medium, which is more similar to what you have in the knee joint, which is the synovial fluid. And so in this particular case, we added high molecular weight hyaluronic acid, which is a big component in synovial fluid in the knee joint. We applied our compression and shear bioreactor. And what you see is just by adding hyaluronic acid into the medium, you actually get much more GAG production, much more matrix production. You get much less hypertrophy, and we end up with a lot more tissue formation. And so again, this is trying to recreate the joint and remove some of these in vitro artifacts. And then a final aspect we're adding at the moment is this type of device, because most of the cell culture we do is done in the incubator, which is 20% oxygen. Well, very few tissues actually experience 20% oxygen in the body. Oxygen's actually toxic, it's a stressor, it's a danger signal. Cartilage has a tissue oxygen concentration between 2 and 5%. Within this system, our bioreactor goes in this side, the larger area. The part on the left is where we expand the cells and grow the cells, and this we keep at 5% oxygen, so the cells never see more than 5% oxygen. We take the bone marrow from patients, isolate it in here, grow it up in low oxygen, and then see where at the moment we're still exploring what type of differences we see. So when you take all of this together, we're bringing together this idea of regenerative rehabilitation. And regenerative rehabilitation is when you do the surgery itself combined with the physical rehabilitation after the operations occurred. And in the area of regenerative rehabilitation, this is cartilage and bone, but there's a lot of activity here in stroke, nerve damage, and very lots and lots of different, especially in nerves in particular, there's a lot of this work going on. So what I normally try to say to surgeons is, when they're thinking about physiotherapy, they're thinking about muscle tone, controlling swelling and stiffness, and regulating inflammation. In vitro studies tend to think about inflammation, tissue damage, tissue building, but we need to think about this as a whole. How can we optimize the cellular response to the physiotherapy we're providing to cells? And so with that, I hope I've managed to convince you that the chondrogenesis from mechanical loading is very different to that when we add active TGF. And in part, it's due to the activation of the TGF. So we're hoping to use this to develop new implants. We're looking at how we can improve the rehabilitation protocol. We're trying to combine this joint as an organ approach. How do the soluble signals of cartilage and bone modulate all of these cell behaviors? And with that, I've collaborated with a lot of team groups over the years. I've had a lot of excellent PhD students and postdocs, and I'm happy to take any questions if that's what the format tends to be.
Oh, thank you very much, Martin, for that really wonderful presentation. Absolutely brilliant. Any questions? Feel free to just unmute and ask. So in terms of the long-term viability and stability, what are your thoughts on the of the long-term stability of mechanically stimulated engineered cartilage when it is implanted? Are there some sort of adjustments in loading protocols that you have considered to enhance durability post-implantation?
Yeah, I think, and I'll just stop sharing because that makes the discussion a bit easier when people see each other. I think that the loading protocol will make a big difference in the stability of the tissue. And when you look at some of the rehabilitation protocols, we're at the moment, we're looking at things like timing. When should you start with load after surgery and how many hours of load per day? And so what we think would happen is, we think, for example, something like an hour in the morning with rest and then an hour in the afternoon with rest would give optimal outcomes. And that's to do with gene, because a lot of these changes are basically a rate of change over baseline. So if you load too long, the load becomes the baseline, so you don't have any beneficial effects. But you have the negative effect of the load continually washing out the newly formed matrix products. So we think you load, increase gene expression, then let the matrix consolidate and integrate into the pericellular matrix, then come back and load again. And so those kind of questions is what we're answering. We're trying to look at the moment. We're also looking at things like circadian rhythm. We know circadian rhythm plays a big role in a lot of responses. So when should you load in relation to your circadian clock? So one thing which I didn't realize till recently, a very common circadian rhythm clock gene is actually PPAR gamma, which is a transcription factor which leads to fat formation. And TGF, that particular transcription factor is actually regulated by circadian rhythm. So we think by these loading protocols and timings, we think we can really change the quality of the tissue and the stability of the tissue.
That's great. So another question was, you were talking a lot about, you had some wonderful experiments there where you apply shear stress. So I know that shear stress, this is often emphasized in weight-bearing cartilage. Could non-weight-bearing cartilage tissues also benefit from shear type loading? Let's say, have you explored applications in areas outside of articular cartilage, such as the ear or nasal cartilage? I know you are AO, so.
Yeah, musculoskeletal. So the answer is no, but I guess it really comes down to, we think the shear effect has a lot to do with this mechanical activation of TGF. And so
Right.
and I think what we also see with TGF is, because we know TGF is associated with scar formation. So what we think is there's a sweet spot of movement. If you have no movement, you don't have active TGF, you don't get chondrogenesis. If you have the right amount of movement, you get the right amount of TGF, you get chondrogenesis. Too much, interestingly, would, in our model, would lead to a very high activation of TGF, which we also know leads to scar formation. It delays bone formation. So, but in non-articular or non-musculoskeletal, we've never looked. So it could
Okay.
potentially help, but the other big difference for those not so familiar is nose and ear cartilage has a much greater capacity to repair anyway, because it has a skin over the cartilage called a perichondrium, which we
Right.
don't have in articular cartilage. And that perichondrium actually helps healing quite dramatically in nasal and ear cartilage. So you might not need the mechanics, which those tissues don't tend to be mechanically stimulated.
Right. Yeah. So Mohan has a question. Mohan?
Oh, thank you. Thank you, Dr. Foxon. Thank you, Professor, for the amazing presentation. I just have like two questions related to sudden risk, and a question which is more like a thought experiment. So the first question which I actually have was about the senescence associated changes when you're dealing with the MSCs and gene expressions and secretome profiles, and how it can actually impact the reproducibility given this type of experiment.
Yeah, that is a very, very good question, because especially because a lot of these experiments are done with monolayer expanded cells, which triggers in vitro aging, which triggers senescence, and this senescence associated secretory profile, SASP, and that's basically causes a bystander effect where the cells which are producing those molecules upset all the cells which are not producing the molecules, and the tissue formation changes dramatically as well. So that will play a big role, but it needs to be considered as two separate problems. One is, how can you reduce the senescence of the cells? And there are ways in cell culture you can change the medium or something like that. You could lower the oxygen tension, which is why we're looking at oxygen tension specifically. That's a stressor that leads to more senescence. The other option is, there's a lot of molecules out there called senolytics. And senolytics have the ability to kill off the cells which have become senescent. And this is a really active area of research, which I don't work in yet, but would love to, because what it shows is that fewer high quality cells is better than lots and lots of cells where there's also some senescent ones in there, which causing these bystander effects. So I would look at this approach of try to manufacture or produce the cells in a way which limits the number of senescent cells, reduce them by senolytics, and then apply the stimulus such as mechanics.
Okay. Thank you so much, Professor, for the question. Sorry, for the answer. Another question which I have is more like during your experiments, have you observed any sort of neoplastic transformation when you basically apply this kind of mechanical stress in this model?
Yeah, I mean, the answer is no. We've never really, but MSCs don't tend to do that anyway.
Okay.
In reality, though, again, just to be completely scientific accurate, most of our experiments are too short to look into that. I mean, we would grow the cells in culture for maybe a week or two to grow them up. We would load them for 4 weeks.
Mhm.
So to reliably answer that question, it would be really hard anyway in vitro. You'd have to implant this stuff into animal models, for example, and see do you get neoplastic changes and angiogenic and vascular infiltration 6 months, 12 months, if you really want to be accurately. I mean, I can say no because it's just too short. Would it still be a problem in 12 months' time? The evidence would suggest not, but I don't have conclusive proof.
Okay. Thank you, Professor, for the answer. The last question is more like the question of like what if. Going through your presentation, you brought up terms about like mechanical conditioning and also the use of like heat maps. So for some reason, I was just thinking that is there a chance wherein we can use thermal preconditioning rather than mechanical conditioning to further enhance the survival of this given model? And also other things like, the differentiation capacity and whatnot.
Yeah, that's also quite a good question. There are a lot of people, what they're trying to do is they're trying to combine thermal treatments with directed targeted activation of implanted materials or microvesicles or those kind of things.
Mhm.
There's some effect of thermal stimulation on cells themselves. The data is not very consistent, probably because of all the other factors, such as the exact matrix the cells are in, the type of integrin binding they have, connexins, all of the other signals going on. That's one of the big disadvantages with all the lab work. We have a very clean system, whereas if you put things into a patient, you're going to have TGF, FGF, VEGF. The cells have receptors, they get all of these signals, and they come to one choice decision. So that becomes then really quite complex. But as an activation mechanism, for example, vesicles, which can be thermally activated, that people are looking at that. The other thing I would consider when you're thinking of cell survival in an animal model or a patient is always keep in mind, at the moment, there's a big transition of the field for MSCs where they're talking about the cells as signaling molecules.
Mhm.
So the cells produce signaling molecules, they produce secretome, and the differentiation is not so important.
Mhm.
But those cells have been monolayer expanded under 20% oxygen. So the cells which survive, it's a selection process. The cells which survive like high oxygen.
Mhm.
Then you can pack them into a very small defect with no blood vessels, and all of a sudden they go from a very high oxygen to a very low oxygen. So in my mind, it's not completely surprising the cells die off because they're oxygen starved. Dying cells release molecules, as do senescent ones. So if you expand those cells under low oxygen and remove the oxygen stress when you implant them, we think you'll get a very, very different survival response and a different secretome response, which is something else we're actually working on at the moment. A very good
Pretty
questions.
cool. Yeah. Thank you. Thank you so much for the answers, Professor.
Thank you very much, Mohan, for those wonderful questions. I see Mike is
Yeah.
getting ready to attack you, Martin.
No, not attacking.
Open scientific discussion is how it works.
No, it was a wonderful presentation. I really appreciate the work that you've done so far on cartilage repair. It's quite impressive. I was just curious, when injury models, IL-1 beta is very often problem, I guess, when so had you had a chance to look at or adding IL-1 beta or IL-6 or any inflammatory cytokine to your constructs or your modeling to see how that may affect repair?
Yeah, I mean, this is there's a few different arms here. So the first is if you add, we haven't done the studies, but I know the group very well which has. If you add IL-1 into the system, you pretty much obliterate chondrogenesis. You just don't get any. Then the same group, which is Chris Evans, he was in Boston, now he's at Mayo. He started looking at if you overexpress IL-1 receptor antagonist, and this ratio of IL-1 to IL-1 receptor antagonist, that then you can rescue some of the situation. What we've done in a study we published earlier this year was we think to some extent adding exogenous IL-1 complicates the situation to the point that in a patient you can try to resolve the inflammation, whereas if we're continually adding IL-1, then by definition we can't resolve the inflammation. So what we're trying to do as part of this whole concept of producing a knee in the lab is we do co-culture where we have synovium membrane, which is the most common source of inflammation in the knee. You can then trigger the synovium with IL-1 to basically trigger the initial inflammation. We can co-culture this with the cartilage. And now we're trying to look at ways that how can we dampen down the inflammation in the synovium to try to think about how could we use that information to help better treat patients. But the very short answer was the very first one I gave. IL-1 will completely ruin chondrogenesis. So any surgical procedures, we seriously should be thinking about reducing the acute inflammation to allow the healing to take place. A lot of the stuff I present today, if there's an inflamed joint, it will not work.
But yeah, that's a very good point. And that's a good point also to address inflammation first. Target that before the healing, the repair. Yeah, that makes perfect sense.
Because what's often overlooked is in a surgical procedure in the knee joint, even if it's just with arthroscopic, you trigger inflammation in the synovial membrane as you enter. If you do an open surgery, you really upset the knee. And you need to think about the damage we've done gaining access and controlling that synovial damage and the synovium inflammation. And then I think you'll get dramatically better results from even something simple like microfracture, which everybody, well, for those who know, microfracture looks great for the first 5 years because the patient's pretty much pain-free, but they're producing lots of collagen 1 and the cartilage falls apart and the patient presents itself back again in 5 to 10 years. It's a delaying tactic. But I think with the right rehab and the right inflammation control, it could be, there's a very good, I'm not sure if you're a surgeon yourself, but there's a very good, interesting study being done in Mayo at the moment where they're using losartan, which is a blood pressure medication. And this blood pressure medication actually has a side effect that it reduces TGF. And when you give losartan to patients after microfracture, I can't remember if it's an animal model or a clinical study, but essentially losartan is improving cartilage formation after microfracture. And again, it's this bioavailability of TGF and triggering various receptors within cells. So that's also quite cool.
Yeah, that is interesting. Oh, thank you. No, you answered the question.
Thank you very much, Martin, for that really wonderful presentation. It's really provocative to know that all the nuances of cartilage repair. Really wonderful. So thank you very much, everyone. And
I think there's a question in the chat.
Okay.
Is it safe to use thermal application to prevent infections in the given MSE models? Seen a lot of surgeons that use thermal therapy to prevent biofilm formation. I don't think it's unsafe, but I have no proof of that whatsoever. I've never looked at thermal application in our models.
Okay. So thank you, and thank you everyone for joining, and wish you a nice dinner, Martin, and
nice afternoon to everybody over there.
Excellent. Bye.
All right. Thank you, everyone.
Thank you.